Unmasking Hidden Irritable Bowel Disease. Introduction. The Chelicerae family consists of many RNA viruses, most notably including norovirus, which can lead to acute gastroenteritis in humans. Acute gastroenteritis is most commonly caused by viral infection and will typically present with diarrhea, nausea, vomiting, and abdominal pain. A rare but equally important cause of acute gastroenteritis within the Chelicerae genus is sapovirus. It is a positive scent, single-stranded RNA virus first discovered in 1976, representing less than 2% of all etiologies causing acute gastroenteritis. Sapoviruses are almost exclusively associated with young children, especially under 5 years of age. When sapovirus is found in adults, it is almost exclusively affects immunocompromised adults. Additionally, enteric infections with sapovirus have been associated with flares of irritable bowel disease. In this case, we present an immunocompetent patient who exhibited sapovirus enteritis as the initial presentation of their inflammatory bowel disease. Healthcare impact. Discovering a sapovirus infection in a patient with previously undiagnosed IBD can provide valuable insights into the interactions between infectious agents and chronic gastrointestinal conditions. This can contribute to a better understanding of the pathophysiology of such diseases. Case description. A 43-year-old female with no significant medical history presented to the hospital complaining of worsening abdominal pain for the past 8 days. The patient described having a non-radiating pain with her lower abdomen, rated an 8-10 intensity. The patient had normal bowel movements until 4 weeks prior to presentation, in which she started having 4 to 5 daily episodes of loose stools containing mucus and bright red blood. She had presented 3 days prior and had been discharged on oral ceftonir and flagyl, but was unable to tolerate medications due to nausea and vomiting. Upon her readmission, CT of the abdomen without contrast was done, revealing inflammatory changes around the rectosigmoid colon, wall thickening, and reactive lymph nodes, suggesting an infectious inflammatory process. Her labs were significant for an elevated white count of 13.2 with left shift. A stool sample was found to be positive for sapovirus, and gastroenterology was consulted due to lack of improvement and duration of her symptoms. The patient underwent an endoscopy, which revealed antral erythema suggestive of gastritis. A lower endoscopy reported a normal colon beyond 17 centimeters from the anal verge up to the cecum. However, from the rectum to the distal sigmoid area, there was mucosal erythema, loss of normal vascular pattern, and punctate erosions with exudates consistent with colitis. Multiple biopsies were obtained with pathology reporting mild active colitis and mild architectural distortion. Based on the patient's clinical presentation, the colonoscopy, the findings were consistent with ulcerative colitis. The patient was started on a course of prednisone for 8 weeks and daily mesalamine. Discussion. This is a unique presentation of an enterovirus infection caused by a rare etiology. Sapovirus is almost exclusively found in immunocompromised adults and children in developing countries. Furthermore, cases of enterovirus flare-ups causing irritable bowel disease have been reported, though there have been little to no cases reported in the literature in which enteric infection is the initial presentation of a patient having IBD. Additionally, sapovirus typically does not present with mucus in the colon and warranted further workup. There have been some studies in which nitazoxanide was used in immunocompromised patients, which provided a reduction in symptoms and duration of disease. Further studies should be done to assess the possibility of using such medication in immunocompetent patients and having irritable bowel disease flare-ups caused by sapovirus. More research is needed to be done to determine the relationships between enteritis, specifically sapovirus, and IBD.